Welcome to RadPodSquad cases. Painful, swollen red toe 58-year-old female, 2 x-rays, oblique, frontal view, amorphous calcifications distal to the second toe. This is a case of hydroxyapatite deposition disease. Can present like pseudogout, painful and swollen, most likely involves the shoulder, and it can even mimic malignancy. What's your differential diagnosis? You are presented with a frontal view of the ankle. What do you see? And what I'm seeing is that there is a subarticular lucent lesion along the lateral aspect of the talus. Our end of bone lesion is a chondroblastoma, and chondroblastomas occur at the end of the bone, as do a few other lesions, such as you can see here, a giant cell tumor, an enchondroma, an aneurysmal bone cyst. And we have a lot to remember. So when we think of end of bone lesions, it's helpful to have a mnemonic. And our mnemonic is age. So when we think about end of bone lesions, besides chondroblastomas, we're going to think about infection, subchondral cysts, AVN or ABCs, and G for giant cell tumor, E for enchondroma, but also don't forget your chondral cousins of clear cell chondrosarcoma. So chondroblastoma, end of bone lesion. And this is an important one because it's the most common primary neoplasm in this region in children. So when we see an end of bone lucent lesion in a child, oftentimes it's a chondroblastoma that will need surgical resection. Here's a patient who presents with a palpable mass at the medial ankle. Moving right into the MR image, I've loaded up 2 consecutive sagittals and a coronal T1. This is a gradient echo. This is a T2 FATSAT and a T1 image. And what we can see on the T1 image is that there is some lesion that seems to be related to the joint itself coming from the region of the sinus tarsi. We can see this lesion furthermore on T2 image as being related superficial to where the posterior tibial tendon is coming towards the medial navicula. And furthermore, we see that on gradient echo image, a portion of this lesion is seen even better, even blacker, and that's called blooming. And that's right, this is a tenosynovial giant cell tumor of the tendon sheath, also known as giant cell tumor of the tendon sheath. This is an extraarticular pigmented lesion considered to be part of a localized nodular synovitis occurring in the 3rd to 5th decades. What it can do, on x-rays we can see it causes pressure erosions on underlying bone in about 10 to 20% of cases. The mass itself is usually of soft tissue density, but periosteal reaction and calcification are uncommon in this entity. Notice the blooming that's occurring in this lesion from T1 to the out of phase T2. Tenosynovial giant cell tumor of the tendon sheath. Here's another example. MR signal characteristics include both areas of low signal on T1 and T2 weighted imaging. Post contrast, it may show moderate enhancement, but on gradient echo, we're looking for that blooming. We're looking to demonstrate that low signal intensity as seen here in this gradient echo image. Here's a 57-year-old woman, 3 consecutive axial old images through the ankle. And what we can appreciate looking at the structures on the medial ankle, we want to be able to see several things. Posterior tibial, flexor digitorum, flexor hallucis, and the nerve artery vein bundle. And we see almost all those structures here. If we follow this groove, which is the medial retromalleolar groove, that's going to be your posterior tibial tendon. And what you can appreciate is that it is not homogeneously low in signal like the flexor digitorum and the flexor hallucis. So this is a tendon tear. Notice one slice down, it gets even thinner, and then it's empty. So that's actually the tendon edge of the posterior tibial tendon in a full thickness tear, empty. How about this patient, 47-year-old female? Let's identify the abnormality. We have a lateral and an oblique view. First, looking at the tibio-talar articulation, no osteochondral lesions, no effusions. What we can see is the sclerosis at the angle of Jassain and the lateral talar process. Really difficult to pick that up on this x-ray. And of course, what we can see is that there's actually a coalition in this patient as well. Fusion between the medial process of the talus and the sustentaculum tali of the calcaneus in this patient who has a middle facet subtalar coalition. 11-year-old girl, best diagnosis. What you're seeing on these 3 representative images through the left tibia and fibula is a bubbly, lucent lesion. It's extending from the cortical region as shown as the expansion in the cortical region here, and it's lucent, and for the size, there's no periostitis, pathologic fracture, or evidence of aggressive features. This is a non-ossifying fibroma. With regards to the MR appearance of synovial osteochondromatosis, which is correct? Is the adjacent bone typically not eroded? Does it typically show low MR signal and blooming? Are the bodies usually low on T1 and high on T2? Is the involved synovium not enhancing? Which of these is correct? You bet. The bodies are usually low on T1 and high on T2 because they're composed of hyaline cartilage, and it's most commonly found at the knee, 50% of those cases. For the other answers, the adjacent bone typically does have erosions, and the entity that usually demonstrates low signal with blooming is pigmented villonodular synovitis, or PVNS. And in our case, it's true. The involved synovium typically enhances in synovial osteochondromatosis. Furthermore, diving deep into synovial osteochondromatosis, this is a benign monoarticular disorder of unknown origin characterized by synovial metaplasia and proliferation. Multiple intraarticular cartilaginous loose bodies, similar in size. Some, but not all, may be ossified, or all. They have a variety of presentations. Presenting in middle age, 4th and 5th decades of life, adjacent bone typically has erosions up to 80%, and the differential diagnosis is of a joint process. So we're going to include things like PVNS, pigmented villonodular synovitis. We know that blooms. We know these bodies are usually composed of hyaline cartilage, most common at the knee, and that the synovium typically enhances.